Welcome. I'm Kaylee Gallagher. I'm the Vice President of Tech Startup Services here at JumpStart. On behalf of the entire team, thank you so much for being here. We're thrilled to have you at what is the third cohort of our HealthTech Accelerator. So welcome to the showcase. So today we've got a really exciting agenda. We're going to have fun. We've got 9 health tech companies that are going to be pitching. The format is 7-minute pitches. And then we're going to open it up to the audience for Q&A. So Tyler here, our program manager, will be walking around with the mic, and we hope you engage and ask the companies some questions. We're going to do 5 companies. We're going to take a 10-minute break, and then we've got 4 more companies pitching. And then we have a happy hour for everyone to network, get to know the companies. And for the investors in the room that are taking meetings, you have your company name on specific rooms, and the startups will come to you. So before we get into all the fun, I just want to take a minute to, of course, express some gratitude to the community that makes all of this happen. We could not do it with a lot of support. And first and foremost, I want to thank our startups. So thank you for the work that you're doing and choosing to be an entrepreneur in the health tech ecosystem. The momentum that these companies have and them driving to create impact at scale is impressive. And thank you for allowing us to be a part of your journey. Over the last 12 weeks, we've worked very closely with these founders. They have refined their regulatory, reimbursement, commercialization strategies. And today they are pitching and they are all fundraising. So if you've been to any of our showcases in the past, I always ask the group for 2 things, right? All of these companies need connections and they need capital. So everyone in this room has connections they can offer. So whether it's for a customer, a pilot, or to an investor, please, as you're hearing these pitches, keep that in mind and follow up with them after. And then for the investors in the room, you have an opportunity to get in early with some very promising companies and help them really shape the impact they're making in the healthcare ecosystem. So I have to thank my team, whether it's the back-end ops or the front-end team working with the startups. Our group supports 4 accelerators a year, plus all the alumni, in addition to other programming at JumpStart. Each of the companies has had an EIR assigned and an analyst to work with them intensely as an extension of their team for 5 months. So you'll get to hear from some of the EIRs today who are doing our intros, which is always fun to kind of get their perspective on the companies they've got to know so intimately. Each of the companies has access to Burton D. Morgan mentors who have graciously volunteered their time. These are industry experts. We have an internship program that the companies have access to, and a CXO in residence program where they can get fractional support at no cost. So couldn't do it without a great team. And then, of course, big shout out to our subject matter experts. So weekly, we connect with SMEs and they come in and give their knowledge, their time, and their connections to help these companies, challenge these companies, think differently, and again, open up their networks. So we have a lot of industry experts, a lot of investors who volunteer their time. And again, thank you so much. Many of you are in the room today. And each of the companies has received $50,000 of non-dilutive funding. So we believe very strongly that this deep advisory support goes a lot further when you can identify the milestones and put some of that to work. And so we have over 80 plus service providers that have all graciously discounted their services and work with the companies to really drive towards milestones and help de-risk them so that they're ready to go on and successfully raise. So thank you to our preferred partners. All right, so we're going to get into the fun part now, and I'm going to invite up Headquarters is our first company pitching. Howie's going to come up and introduce them, and let's have some fun. Thanks, everyone.
This on? Yeah. So hello, everybody. For those of you who don't know me, my name is Howard Greenman. I'm an EIR at JumpStart, and I focus on kind of digital health companies. And I'm from Boston, and I'm also a parent. I've got 2 young kids, and they're at the age now where they're starting to play a lot of youth competitive sports. And it's essentially taken over my life. I'm sure some of you can relate to that, right? But it started getting a little scary last week when my 9-year-old boy broke his finger playing baseball. And the day after, I went to see my 11-year-old daughter's field hockey game, and right in front of me, someone from the other team took a big shot with her stick, missed my daughter's face by that much, and hit her teammate's face right in the cheek. She fell down, blood coming out of her mouth, and I realized, holy crap, what am I in for? This is pretty scary. And over the last 3 months, I've gotten to work with this company headquarters, who's opened my eyes that not only is the intensity and risk associated with physical injury on the playing field scary, but certain injuries that commonly occur are not treated properly. It's inefficient, the care, it's not consistent, and it just generally sucks. What I've learned about this team is they've kind of literally and figuratively banged their heads trying to solve this problem. And they, because of an incredibly elegant solution and a convergence of things like telemedicine, AI, and a lot of innovation, have been able to put together a really cool solution to a clearly unmet need. Lucas Johnson is one of the co-founders and the CEO of the company. He's going to tell you all about headquarters. Where are you, Lucas?
Right here. Good afternoon. I'm Lucas, co-founder and CEO of Headquarters, where we're making best-in-class concussion care accessible to all. Imagine this. You've been locked up in your bedroom for the 10th straight day. You're having pounding headaches and unable to recall basic information. You don't know when or if you're ever going to get better. Well, this is me on not just one, but 3 different occasions after suffering from concussions myself. And I can tell you, it's truly traumatizing. I ended up in the ER and was told from there to go shut myself off in my bedroom and just wait for my symptoms to go away. So I did for a whole month, just waiting there in my dark room. Until I started seeing other doctors, went to my primary care and multiple neurologists. Unbeknownst to me, they weren't trained in the latest and greatest concussion care, and all they told me to do was to keep waiting. And so I did for a month and yet another, until I started to take matters into my own hands, and I learned of specialty concussion clinics that are out there, but they were nowhere near me, had enormous wait lists and exorbitant out-of-pocket costs that I couldn't pay. I'm not alone in this. There are 3.8 million Americans who suffer from concussions every year, making this a $27 billion market based off of the average insurance payouts for concussion out there. Thankfully though, just 3 years ago, new research came out transforming how concussion should be treated and hopefully making my story a thing of the past. Unfortunately though, experts estimate it'll be another 14 years until these new protocols disseminate throughout the US healthcare system. But we're not waiting. We launched in January and have already had 15 amazing pilots with great feedback telling us how amazing our service is. We additionally struck up a partnership with the largest concussion-specific insurer in the US, helping us really make this service a no-brainer, as one of our pilot users said himself. And lastly, we raised $1.8 million for our pre-seed back in April, allowing us to run for the next 2 years and get to $1.5 million in revenue over that time. What is it that we're building? An AI-enabled virtual concussion clinic made of 2 components. The first, telehealth with these concussion specialist doctors who know the latest and greatest protocols. And the second, our software platform, our AI-enabled rehab that makes it so much easier to deliver remotely as opposed to having to find these specialty places in small pockets of the country. How it works is the next day after you've had a concussion, you hop onto a telehealth appointment with one of our specialists. They use our AI-enabled EMR to better prescribe your personalized plan, and all the admin work is taken off of their plates, so they're focused on you, the patient. From there, you're guided day in, day out outside of your appointments by Hope, our concussion companion who's guiding you along the way and is able to adapt based off of how you're progressing along your recovery. Lastly, we know that there are 7 different subtypes of concussion, and no 2 should be treated the same way. So we have an interdisciplinary team of subspecialists who know how to treat each of these different subtypes and ensure that you're getting very personalized treatment that is aligned with the latest and greatest that most people are not receiving. All in all, it leads to a happier patient and better outcomes, cutting the chances of you having long-term symptoms like I experienced in half. We provide this service to concussion patients, and we get paid back using existing CPT codes from health insurance. 1.3K on average. The way we find those patients is our initial focus is in youth athletics, where we go to athletic organizations that staff athletic trainers. Think high schools, club sports programs, and even hospitals like UCSF we work with in our pilot. They provide these patients to us, and we additionally provide them our software to make their lives so much easier in supporting these concussion patients. And you might think to yourself, well, you must have to give it away to free or maybe even pay them to use it. Well, no, they actually love it so much they're willing to pay us $3K per year as an additional revenue stream. Now, we plan to dominate the concussion market with this model. Again, a $27 billion market, but we're not stopping there. We can apply our infrastructure, our same doctors, to expand to all of neuro rehab. Think long COVID, most topical today, or patients who are in their later stages of rehab post brain surgery and stroke. With this, we can serve so many more people in the country and across the entire globe. Now, when it comes to the concussion space, really matters is two things. The first is speed to recovery. We want to ensure we're helping people get back to their lives as quickly as possible. The second is accessibility. So you don't have to drive there, you don't have to wait, and you don't have to pay crazy out-of-pocket fees. We've studied the market in those two spheres, and we see a huge gap in the top right, obviously. And we fill that gap. Now you might think to yourselves, concussion is such a niche market. There's no way you can make an enormous business off of this. Well, we are able to because we have enormous gross margins, and it only takes 2% of the market to get to 100 million in ARR. We've got the best team to do so. Outside of having been a concussion patient 3 times myself, I used to lead teams at GE Healthcare developing new medical devices and building teams together to develop new technology. I'm also joined by Orestes, my co-founder and our CTO, who is a badass engineer who has built AI backends for startups and government after getting 3 degrees at Penn. Additionally, we have an amazing team of medical advisors coming from the top concussion clinics in the country, guiding us on the newest, latest, and greatest protocols and how to best treat this condition. Now, where we're going next is we're validating this business model after having just recently raised. We're focused first on building our team, hiring up our clinical team and amazing doctors in this interdisciplinary specialties, as well as engineers. From there, we're validating an insurance reimbursement. We just recently started striking up conversation with a group called Bridge to help us lean on their insurance contracts to do so extremely fast. Lastly, we are validating that partnership with Headstrong Concussion Insurance to really make this a no-brainer, and are using it to help us get to 50 organizations in working with us for this fall sports season coming up in just a couple months. Now, how we'd love your help is we'd love introductions. First and foremost, like I mentioned, we're looking to get to 50 schools and clubs this fall, and if you happen to know any high school athletic trainers or club sports administrators, we'd love to speak with them. Additionally, if you know any rockstar full stack developers to help us build this amazing product and make it even better, we'd love to speak with them. Additionally, past youth athletics, we're looking to get into hospitals, and we want to chat with them to be able to have their ER discharge concussion patients sent to us. And lastly, any former pro athletes who have a personal tie to concussion, we'd love to speak with them. Again, we're headquarters, and we hope you join us at the headquarters of the future of brain health. Thank you.
Thanks so much, Lucas. If there is anyone that has a question, we have 1 to 2 minutes after each presentation to ask a few questions. So just put a hand up and I'll run over to you and we can ask it. All right, I already have one. Normally I have to beg and grovel.
Great presentation. Daniel Dudley, Yatro Advisors. I was curious if you have any concerns around kickback requirements with regards to sourcing patients?
Yeah, so we are a clinic ourselves. So the patients work for us, and we set up a model that is typically done by other telehealth companies. If I get into the details, it's called MSOPC. But how it works is our tech company works on the front end and optimizing how we bring in patients. And then with our clinic, we're getting paid through just like kind of classic insurance reimbursement. There's not, say, Yeah, I guess we're not recreating the wheel in terms of like something that could be at risk of kickback laws.
Lucas, you're not paying the athletic trainer. Right?
No. Yes. Yeah. To help clarify, so referrals coming into us, we're not paying for those referrals, which maybe would be what brings up a question mark. Thanks for clarifying, Howie. Yep.
All right, one more question.
Sorry, I don't
Is there
understand.
one here? Yep.
Thanks, Lucas. Can you talk a little bit about how the FDA looked at this thing, especially when you they're really hesitant about AI.
Yes.
So are you presenting just information to the doctor, or are you actually telling him these look like what the problems are, what they should do?
Yeah. So we have AI working in two sides. So on the clinician side of things, is removing all of the admin work off of their plates. It's not making medical recommendations. On the patient side of things, it's a mode of delivery that's more usable for our concussion patients. So 70% of patients, they struggle with screen sensitivity. So if they're having to stare at their phone or a computer in order to be delivered care, it's not going to be very useful to them if it's triggering headaches and dizziness and such. So we have a voice AI companion that guides them through and allow it to be super engaging all over voice. But it has guardrails that are set by what our clinicians have defined for their care plan. So it's not actually making decisions itself that are outside of what the doctor has prescribed.
So is this a class 1 device then?
We're not a medical device. Yeah.
All right, thank you so much. One more round of applause for Lucas.
Thank you.
And if you have more questions for Lucas or headquarters, all the companies are going to be around during the happy hour after the pitches. So next up, we'll have Nurture and Kristen, and I think we have Howie again, twice in a row.
So I spent a good deal of my career working for companies that create predictive models and genetic tests that create insights for patients and clinicians. And a lot of those things ended up getting shelved because they were not actionable. Creating a test that would predict someone's willingness or excitement about drinking root beer was not really a useful test, right? The challenge is a lot of the times, and you'll find when we learn more about this company, Nurture, a lot of the times insights and predictive models, they can't lead the physician or the patient to do anything. There's no actionable, thing to do. What Nurture has done so brilliantly is they figured out how to predict and risk stratify and potentially diagnose something that goes often underdiagnosed. And they married it with risk prevention and treatment, something actionable for the patient and the clinician to do. They are doing an unbelievable job with women's health and one of the most underdiagnosed conditions, I think, in the world, which is depression and postpartum depression. Kristen Ellefson, the CEO and founder of the company, has done a miraculous job, and it's been a delight working with her as she's navigated the complexities around collaborative care models and OBGYN reimbursement, and has landed on an unbelievable technology and platform and team, and I can't wait for her to tell you all about it. Kristen, where are you?
Awesome. Thank you, Howard, for that incredible introduction. And I'm so excited to go deeper and share how Nurture is pioneering prevention of postpartum depression using AI and clinically validated protocols. And I became very interested in this problem when my best friend experienced postpartum depression herself. And what I learned is that 85% of women are going through this. And just like her, they're falling through the cracks, not receiving care. And sometimes, like her, they're actually hiding their symptoms because they're afraid their child will be taken away. Given that this is actually the #1 complication of childbirth, with 1 in 5 women experiencing this, it's really shocking that we're letting it fall through the cracks so frequently. There's a 2x rise in the past decade alone, and this is costing payers $80 million per year on average. So this big problem is only getting worse. And part of the problem is that postpartum depression is such a misnomer. Guys, more than half of all cases actually start during pregnancy, which is why OBGYNs are the best positioned to catch it. but they're not mental health professionals and they struggle with existing tools in the very short appointment windows. We also have a reactive healthcare model that focuses on the postpartum checkup. But guess what? 40% of women even skip that checkup. So you simply can't screen a woman who's not at this appointment. So the reactive model is failing us. And it's also exacerbated by a shortage of behavioral health clinicians. Unfortunately, there's not enough of them to take care of the existing patients today. That's only getting worse. And this tells us that any solution in the space needs to leverage technology to make the existing clinician base more efficient and more effective. Guess what? That's what we're doing at Nurture. We are using AI to predict, prevent, and finally treat postpartum depression, starting with our universally accurate prediction model, leveraging AI to diagnose patients before symptoms appear. We then take our high-risk patients and onboard them into our preventative self-guided therapy based on a clinically proven protocol to prevent more than half of all cases. We tie all this up with a telehealth component that allows us to treat all the patients that do go on to need support and generate revenue for all parties. But again, that status quo is quite sad. Only 15% of patients today are receiving care. But with our revolutionary prediction models, multiple modalities I can really nerd out on, we're able to identify all these patients in advance using pre-pregnancy features. So we can tell you at that very first intake appointment with the OBGYN. From there, we take these high-risk patients and onboard them, introduce them to Naomi, who walks them through different protocols, teaching them resilience, outreach to network, challenging black and white thinking, all of these things that are clinically proven as a protocol to prevent more than half of all cases. We've broken it into easy and engaging content. We're in multiple languages, but most importantly, we're building a high-touch digital relationship with these patients so we can do more frequent mental health screenings. And as soon as they meet the criteria for any perinatal mood and anxiety disorders, we're now treating them with something called collaborative care model or other behavioral health interventions that are reimbursable and supported by the OBGYN. In this model, the OB actually manages the payer contracts and even does the billing on our behalf, allowing us to treat the patient with existing CPT codes. All of this lets the OB focus on their practice and also differentiates that practice in these crowded urban environments. But at the end of the day, there's also a revenue component. We're generating over $1 million per practice with $300,000 going back to that OB. So today the TAM is about 18 billion, but keep in mind that's only 15% of patients that are actually being treated and captured in this number. With Nurture and how we're able to open up this market to capture the additional 85%, we're looking at a 120 billion TAM, and we're uniquely positioned with our technology and language abilities to establish ourselves globally. We're starting with OBGYNs and able to generate about $1 million per practice, but we're very excited to solve expensive problems for payers and employers. The average payer is losing $80 million per year in downstream costs associated with untreated postpartum depression. It's the tip of the spear for your health in general during pregnancy and leads to higher NICU utilization, C-section, preeclampsia, and gestational diabetes, to name a few. And that's before we go on to the additional absenteeism and turnover we see in employers in the space. So starting with OBGYN clinics as our beachhead is really a strategy that allows us to get the real-world clinical data outcomes we need to sell into the payer space, where we have much larger revenues, more scalable, and bigger margins as we just focus on the technology component. So there's just a couple other plays in the technology space here, but we're the only ones doing early and scalable prediction, which allows us, again, to be the only ones doing prevention and really tackling value-based care. We're also the only ones doing integrated OBGYN, seamless billing, and existing CPT codes. But one way I like to think about it, other groups are just focused on a smaller market. We're focusing on the 85% and the 15%, allowing us to capture and own the patient from the earliest stages of pregnancy. Why do we care about this problem? I saw my best friend go through it when I was a nerd at MIT, so I had access to some of the best AI in the world. And that's what we did. We got mad about this problem, and we decided we would use this technology to predict, prevent, et cetera. We put together the best team in the space, academic researchers, et cetera. And we're really excited to share that we're patent pending globally. We're already strategically implemented on both coasts and have agreements for over 1 million that have been signed. But where do we go from here? That's the past. What I want you to think about is what's next. First of all, my background is sales, sold into every channel of healthcare with a history of 10xing revenue. And I just got joined by one of the best. Peter Baywin has overseen 250 salespeople in the cord blood space, which is a perfect one-to-one for selling into OBs with our unique model. We also have an exciting patient-driven demand opportunity coming up that we'll be sharing this fall. But we're raising $500,000 to act on this, and we need your help so that we can raise $127 million ARR by year 5, touching just 5% of pregnancies. So with that, I'm hoping that you guys will help Nurture to be the beginning of the end for postpartum depression. And thank you so much for your excitement.
Thank you so much, Kristen. If there's 1 or 2 questions for Kristen, one in the back here. Okay.
Is the clinical utility of preventing postpartum prevention pre your solution, but just if one knows early, is that accepted, or is that something you have to prove out that these can be prevented if we see early signs?
Yeah, it's been clinically proven, the prevention effect of 53% with 6 clinical trials. And I can grossly oversimplify postpartum depression here. We can think of it as 2 different channels. Essentially, we have body, hormone changes, et cetera. And the lifestyle change is the secondary pathway. So overnight, you're isolated, sleep deprived, and need to ask for more help than ever before. So our interpersonal therapy targets that pathway.
Time for one more quick one. Andy?
I'm loud enough. The $500,000 you're raising, what's the basic structure of that deal?
Yeah, so we're raising a SAFE and looking for that to really focus our sales sort of OpEx to kick that team up and get us into the OBGYN space. Raising it on, so happy to discuss more though.
All right. Thanks so much. One more round of applause. Thank you. Next up, we have Gary, who's going to come speak about Avianova.
Nasal network that's interesting. Really? Yeah. So great to see everyone here. Thank you for joining us this afternoon. Is this on? I can shout loud anyhow. If it's better. So my name is Gary Smith. I am an EIR here with JumpStart. I've built 35 years in the medical device and diagnostics industry, commercializing new technologies with physician and vendors, scientific inventors, et cetera. So really excited about the cohort that we have, this 3rd Trailblazer program. And I'm really protective and excited about the cohort members that I'm working with, the founders that I'm working with. I want to tell you a little bit about Noor Taj Tamim. Noor is energy. I've been working with her now for 4 months. I had to take a few notes so I got things straight because she's got such a long list of things she's been involved in. Really excited. She has incredible background in bioastronautics research. She's a NASA entrepreneur. She's a recent TechStar grad and recognized 30 under 30, 25 under 25, somewhere around there, in entrepreneurs. Her company, Avianova, is creating a highly innovative platform to non-invasively treat vertigo and other movement balance disabilities or issues that we have. And I don't know how many people in the room are thinking about this. I try not to think about it, but we're on the verge of personal space travel. We're on the verge of air taxis taking us around and being in vehicles moving where we're not necessarily the controller of those vehicles. And for me, and I grew up sailing on Lake Erie and taking a lot of Dramamine to keep my vertigo in check, there's a lot of changes. And Noor's taking advantage of these dynamically growing markets as well as addressing this at the healthcare level. Noor's always on the road, meeting with potential customers. She has secured commitments across aerospace, space travel, air taxi, the cruise ship industry, and indeed Department of Defense, Department of Air Force and military as well. So please welcome Noor Hajj Tamim.
Hi everybody. I graduated my bachelor skydiving, so I'm gonna so I'm just gonna hang out here. It's okay, it's fine. Thanks. I'm Noor Hajj Tamim, a private astronaut candidate, and when I was selected, I thought nothing could stop me. But then a vertigo diagnosis disrupted my training and landed me in and out of hospitals. What I thought was a personal setback turned out to be a much deeper issue, because just as it's a problem in space, it's a problem here on Earth. 40% of Americans experience balance issues like motion sickness or vertigo, and since starting Avianova, I've had people come up to me after every talk, not just to say that they have the disorder, but to share how it's changed their lives. I've heard about missed milestones, lost careers, and daily moments stolen by uncertainty. Recurrent vertigo and balance disorders cost the U.S. healthcare system an estimated $48 billion annually. Yet current solutions aren't built for moments that matter. Medication can take up to an hour to work and cause sedation, and surgery is invasive and limited to a small group. And there's no wearable technology that supports balance loss in real time until now. Introducing Gravitone, real-time stabilization earbuds that work in 3 simple steps. Cool. A gentle cooling pulse soothes your inner ear, slowing disorientation before it begins. Stabilize. By quieting the ear signals, we prevent dizziness, nausea, and balance loss. And optimize, using an ultra-efficient cooling material, long-lasting comfort on minimal power. Unlike pills, Gravitone acts instantly with 0 sedatives, 0 impairment, and 0 downtime. Now, how exactly are we going to get there? We're actually going to sidestep a little bit first and focus on the motion sickness segment, where balance is more preferable, and unfortunately so many of us do deal with the seasickness and the air sickness as well. So we've developed 2 technologies. The first one is more for consumer use. They're disposable and they don't use electricity. Essentially what happens is the user cracks the cooling agent like a glow stick. There's a delaying agent and the cooling agent itself, and what happens is these earbuds slowly cool down your ears for a duration of 1 to 2 hours. Now, given our previous conversations, we've hit the tourism sector as a firestorm, honestly. We have interest and customers already lined up within the aviation sector, so the island hopping, such as like the Hawaii flights, air taxis, and the expedition cruises as well. So I'm really excited for that because hopefully they let me go to Antarctica with them. Snag that out. The other device is the one I'm personally excited about, being someone who deals with vertigo disorder, Meniere's disease, which really sucks, especially because you start to not be able to hear anything and you rely on either surgery or, you're not allowed to use salt, caffeine, and it just kills the vibe for a 21-year-old, honestly. Like, no alcohol either. But anyways, this device itself, we actually started product development on it in 2 days ago, right? Super, super excited for this because we're working with an incredible crew called Nonfiction. They are space-centered but also medical-centered at the same time, and this will make sense in a second. Other than that, we're working with Ohio State to validate our results out of this technology, and again, super, super excited for where this takes us. Other than that, cooling application itself isn't just for vertigo. It's been proven to help restore hearing function and preserve hearing function in both ototoxicity, which is cancer and chemotherapy-induced hearing loss, but also sound-induced environments as well. Other than that, we are also exploring Parkinson's disease and relieving tremors as a future use case. So we've secured a manned research flight aboard Halo Space in 2026 to monitor and protect passengers aboard the spacecraft, validating Gravitone in one of the most extreme environments possible. we actually also secured a second space flight. You guys are the first to hear about this with Virgin Galactic aboard their ISO2 Delta Diary series with astronauts Kelly, Shauna, and Nora already identified. Not only are they actively working with us, but they're helping us set the standard for how these earbuds will be used in space. Once these earbuds go up with Virgin Galactic on their first flight, we aim to mandate these into all passengers' ears, and Virgin Galactic is shooting for 125 space flights a year starting in 2027. So I'm a solo founder, but not lacking in experience. As Gary had mentioned earlier, I've worked in tech commercialization with NASA from literally everything from ice on airplane wings to pyrometers, and I've also worked in the medical side of astronautics as well. I've taught at University of Oxford for aerospace principles, and again, I'm a bioastronautics researcher. Absolutely love that job. We have two incredible advisors with us. Alan Gilbert, he was our EIR at Techstars, and he was with Cover My Meds early on for product development and team building. And Laura Atkinson, she's our healthcare and strategy advisor. She's built and exited 4 different healthcare startups to CVS, Human, and other companies. So far, we have commitments across defense, private space, and healthcare systems, but once again, really excited for the motion sickness segments, especially because our initial customers are abroad, and we will be starting this in the fall. So over the course of this year, building out that first product and getting it to the hands of our customers, this gives us the great opportunity to have our customers tell us what they like, what they don't like about these earbuds, especially as we begin mass production and bring them back to the States. And a little bit of background on that, those customers include Ocean View Expeditions. They do the Antarctic cruises, they're based in Belgium, and then we have the air taxis that are going to start operating in September in Dubai. And once we are more comfortable with the motion sickness segment and have begun clinical trials in early 2026 with Ohio State University, we plan to expand into the vertigo segments. Our end goal for this technology is to license it into either commercial hearing aids, because as you have vertigo, you start to lose your hearing in the process. Anyone who's talked to me, my friend Dean here, I can't hear a word he says since day one. And then other than that, commercializing this into commercial earbuds as well for the motion sickness purposes. We're looking for our next customers, from training centers and clinics to pilot Gravitone to experience instant balance support. Once again, my name is Noor Hajjameen, and thank you so much for your time.
Thanks so much. Do we have any questions?
Yeah, I'd be interested in your commenting on your intellectual property. What is defensible and indefensible in sort of your workflows and form factors, et cetera?
Absolutely. So we're working with an incredible lawyer right now. We have 2 provisional patent applications on we're working on the motion sickness one as well as a previous one that we've had in the past. We're securing an exclusive agreement with UC Davis for their aerogel technology so that we're able to keep the earbuds colder for a longer period of time. Otherwise, if we were to rely solely on electricity, these earbuds would be really big, bulky, slow, and they wouldn't be able to cool as we really would want them to. They'd be quite ineffective. We also plan to secure a utility patent on the temperature ranges so that if any other company were to try this in the future, their cooling ranges would be placebo. Other than that, we are going to secure global patents as well because, again, we are working kind of everywhere right now.
Great. Time for one more question. One quick one, if there is. All right. Thanks so much. One more round of applause. All right. Next up, I believe we have Soroxo, and we get to hear from Gary again. Amazing.
So thank you again. Want to make sure I'm so fortunate that each one of my founders has such a strong background and so much to cover. We want to be able to do that. So let me pull up my notes here. So let me introduce you to David Sarfi. Dr. David Sarfi is co-founder and CEO of Soroxo. some amazing technology he is in the process of bringing to market globally that will address a very concerning issue that healthcare systems deal with respect to sepsis and the ability to monitor sepsis in cancer patients and patients with a wide variety of diseases is a challenge, and that the current testing mechanisms, markers that we're looking at may take days to be responsive and provide the clinician feedback. Sepsis moves very quickly, and as David will share with you, really the challenges involved in monitoring and managing this killer. An interesting thing about David is he's born in the USA. He resides and lives in Cambridge, England, with his family. We're trying to get him back. We actually don't have to try to get him back. He's moving the company to Cleveland, Ohio. Has been very active in the process of that and establishing a beachhead here in the US for Siraxo. David has not missed any of the meetings that we've had during the cohort. We've had 3 meetings here on the campus, flying back and forth from the UK. Thank you very much for that, David. He's always willing to take a meeting at what's convenient for my schedule, like 4 o'clock in the afternoon, which of course puts him at 11 o'clock in the night in Cambridge. 11 o'clock.
Something like that, yeah.
And then we've been joined by Zinat here with our group. And of course, Zinat was halfway around the world at another time zone, so she was joining us at 3 o'clock in the morning. But that's the dedication that the team has, the energy that David brings to the challenge that he faces with this technology. Thank you, David.
Great. Thank you very much, Gary. Okay. Is that not working? Oh, okay. Can you hear me? Great. Imagine a loved one is taken to the emergency room with severe infection. The doctor starts talking about, mentions the S word, sepsis. You start to get nervous. You know that sepsis is a very debilitating disease and can lead to death in 30% of the situations. You also know that it's time critical. Every single second counts. Not only that, but every hour that passes before treatment increases the risk of death by 8%. Sepsis is responsible for 1 in 5 deaths across the globe, 1 in 10 deaths here in the United States. You ask the doctor, what's the prognosis? He says, I won't be able to tell you for 24 hours. Well, why is that? I'll tell you why. Because the biomarkers that are in use right now are not good enough. There's a 24-hour lag between when a patient's condition changes and when the biomarker changes. That's not good enough. It's like driving a car with a speedometer that tells you how fast you're going yesterday. It's just not good enough. You ask any ICU clinician, they will say it's not good enough. We at Siraxo, we say it's not good enough. We have developed the leukocyte immunotest, the LIT, to address this issue, to absolutely address this issue. It's a handheld test. It uses disposable reagents, and it allows us to develop this new, deliver a new blood-based biomarker that measures a very important aspect in the blood, the white blood cell, the neutrophils, and the ability of those neutrophils to produce what's called reactive oxygen species, ROS. This is something that clinicians have wanted to know for many years, but they've not been able to do it because it took too long to measure. Now they can do it in 10 minutes right next to the patient. That is transformative, absolutely transformative. It's easy to use, it's affordable, and we've already demonstrated superior performance. And this is the most important thing. Look at the lag. There's no lag. The lag is gone. Our biomarker responds in about in minutes rather than hours or days. That will transform medicine. Clinicians will have better control, and it will lead to better outcomes. We've got a very strong data package already that we've done in 10 studies in over 600 patients all around the world. You can see we've already shown superiority over current biomarkers in terms of accuracy, sepsis detection ability, speed, and the predictive ability of this biomarker. We own the biomarker. That's an important thing to understand. It's a massive market, growing and underserved. And we are going to transform the way that this is addressed. You can look at, we have broad applications, not just in sepsis, but in infection, cancer, organ perfusion. I'll talk to you more about that in just a second. It's a $15 billion TAM with 1.15 billion SAM, and we're going to be targeting $45 million by year 3 using this technology and growing this. In terms of our go-to-market strategy, we're going to start by looking at ICUs. So the middle box there, and we're going to be addressing this lag that we've talked about. It's a 15% reduction in sepsis treatment costs that we can deliver with this tool. The emergency departments, the ERs are going to be extremely interested in this because we detect sepsis quicker. We will have huge impact on patient outcomes. But let's talk about the final box, organ perfusion. This is a sector that has come to us. We had Cleveland Clinic approach us a year ago saying, we love what you're doing. We want to use this to monitor ROS in organs, in their case, livers, because up until now, it's taken too long to be able to measure this. They need to know this, but they haven't been able to measure it until now. Our test completely and radically addresses that issue. So what we're doing with the Cleveland Clinic, that's generating revenues right now, 24,000. That's from a single center. We're already got another center just starting the piloting in Duke University. 2 more centers here in Ohio, University of Cincinnati and Ohio State will be piloting very shortly. And we're going to be expanding this all across the country. I was down at the Cleveland Clinic yesterday. They were saying this is such a comprehensive, fundamental, universal tool. Every single organ procurement organization in the country is going to want to be using this tool. So we're hugely excited about this. And what will this do? This will enable them to make organs more available to the people who need them. It will radically change the way that that's being done. In terms of our traction, you can see we already got proven traction in terms of with organ perfusion. We're going to expand that more fully in the next few months, given the money that we hope to raise here over the next few months. Talking about the clinical pathways, we just started a trial at the John Radcliffe in Oxford just a week and a half ago. That's started now. That's in sepsis. We're going to be starting a multi-center sepsis study here in Ohio, so Ohio Health, and with UH and also University of Nebraska. We'll also be doing a European study. All of these will lead to launches in separate in the separate jurisdictions, as you can see. The bottom box, I just want to point this out. We will have a lot of interest from the big players, the Abbotts and the Rushes. They will be very interested in licensing this technology. We have very strong IP, patents already granted in use of this in sepsis, patents granted in use of this in cancer, as you can see, and patents pending in use of this in several infectious diseases, and strong endorsements as well. A strong, committed team, very experienced. My background, I was one of the founders of PowderJect. It had an $878 million exit. Rubina has been working in leukocytes for decades and hugely experienced in this. And I wanted to point out Professor Paul Moss, one of the leading immunologists in the UK. So just in summary, we have a proprietary biomarker that we own. We have a strong team and we have strong traction. We've done all of this on $900,000 in dilutive funding, largely from grants, 300,000 of which are still in play right now. The ask, we're looking for $2 million to get us to UK regulatory launch and product launch in the UK. I hope you'll join us on our journey. Thank you very much.
Thanks so much, David. Any questions for David or Saraxo? Yeah, here.
Great presentation, thank you. A really good friend of mine died right here in Cleveland, at the Cleveland Clinic, from sepsis. And the issue that I understood was, it's not whether or not she had sepsis, it's what was causing the sepsis. And it was a very, very unusual organism or whatever, from a swim in a pool with an open cut, never do that. And I just wanted to understand how this fits or speeds or changes the current protocol towards identifying what actually needs to get fixed before the sepsis goes away.
So our particular tool won't help identify, we'll not say it's this bacteria or that fungus or that virus. What it will do, we'll be able to tell you very quickly much more quickly than CRP or procalcitonin. Is that patient responding to whatever treatment they're on? If they're on an antibiotic, what you have to do is when you get on the antibiotic, you have to wait 24 hours to know if it's working. Because it's not because the patient isn't changing, it's because the biomarker isn't changing. Ours changes virtually instantly. So you have a lot more control, a lot more responsiveness than you would have with the current technologies, especially C-reactive protein and procalcitonin. So that's where it really helps.
All right, one more question here.
Is the excuse me, is the biomarker that you own the only one that would provide this information, or is there a possibility of a competitor, owning another biomarker and coming to
Well, I
market
mean,
with
obviously we
something
can't
similar?
predict the future is one of the hardest things to predict, as I've been told. But basically, there are other people have tried to do this, but no one else, because we demonstrate that the fact that we have patents already granted for use of this particular biomarker in sepsis. Now, it is possible someone could come up with some other alternative. The other people looking at DNA, PCR and these kinds of approaches to do this. But in terms of this biomarker, we've been working this for a number of years. We're very familiar. I think it's going to be very hard for someone to invent and develop something that does this, directly like what we do. In my mind, I think what would happen if they're going to, rather than spending the millions that it would take to do that, they'll come to us and want to take a license. That would be my expectation. But.
All right. Thanks so much, David. One more round of applause for Siraxa. All right. And after this next company, we'll take a brief break, but Gary again.
So, pleasure to introduce Andrew Weem. Dr. Andrew Weem is our next presenter. Andrew has been a pleasure to work with, and I'd like to talk about our founders and CEOs and their personal personalities in some ways. So I love to tell the story, Andrew. It's not like you don't take on a lot of challenges or afraid of any kind of challenges. So Dr. Weem starts Resilient, right? A couple of years ago, a year or two ago. Finishes his PhD. Joins the JumpStart Trailblazer program. Moves his wife to Columbus. He and his wife have their first child right at the start of the program. That's not like stress in his life, is there? And he's starting a company at the same time. Now he's raising additional capital to achieve market entry. He's working on a very innovative 3D platform for improving cosmetic and clinical outcomes for women undergoing breast lumpectomy procedures and other breast cancer care issues. So please welcome Dr. Weem.
Thank you, Gary. One in two women are going to find a lump in their breast in their lifetime. And that means that if this were to happen to you or a loved one today, there would be no good clinical solutions to address the physical and psychological outcomes of the breast cancer surgeries. One in two. I'm Dr. Andrew Weems. I founded Resilient Medical and co-invented the Bravo scaffold platform as a solution to this problem. Last year, 370,000 breast cancer diagnoses were made in the US, and the CDC expects that there will be more than 430,000 by 2030. There were also more than 500,000 lumpectomy surgeries performed in the US, greater than the number of diagnoses that were made. As we become better at early diagnosis and screening, these numbers are only going to continue to rise. And this is important because lumpectomies represent more than 3% of all major surgeries done in the US today. And despite this prevalence, there are still a number of limitations that patients know of going into these procedures, including that there is a high likelihood of cosmetic changes associated with a lumpectomy, including dimpling or collapsing of the breast, which has enormous psychological implications, pain associated with healing, after the surgery, and even complications or prevented healing of the surgical site post-surgery, and an increased risk of secondary cancer related to the radiation therapies that are a requirement for successful lumpectomy procedures. So what Resilient Medical has developed is the Bravo scaffold, which is implanted during the lumpectomy procedure. And as soon as it enters the patient, it immediately begins providing mechanical support to the surgical site, thereby reducing the cosmetic change that otherwise would occur without it. Over the course of its lifespan, it will also allow for infiltration of native tissues, and it will slowly erode over 12 to 18 months, ultimately leaving behind nothing but native healthy tissue that has not had any cosmetic changes after the procedure. During this time, it also will serve as a radio target to provide better accuracy, thereby reducing patient risks for radiation boost that would be otherwise delivered. We've validated the performance of the Bravo and our regulatory strategy of navigating FDA with third-party consultants, and we have multiple US and international patents that have been awarded to date. If you look at what is existing in the space currently, there are a number of off-label use devices that have been applied by clinicians in breast cancer care. But predominantly, they focus on mechanical support and the resorption time, how long they're present in the body. They do nothing to address the cosmetic outcomes, and they do nothing about radio targeting. The Bravo is the only product that will be available that offers this unique balance of characteristics necessary to fully address the complications with lumpectomies. And this is very important in a $1.5 billion market. Of our beachhead market of 270 million, it is predominantly made up of clinicians who know that there have been poor performances with other devices, who want the 3D aspect or the cosmetic aspect for their patients, and patients who are specifically choosing surgical procedures because of the cosmetic outcomes and ultimately the psychological implications of what surgery they choose. Early sales of the Bravo will be driven through a distributor-led model, $1,200 price point, and a 93% margin for Resilient. And it will be reimbursed under existing insurance CPT codes. Downstream, we will be able to expand into mastectomy markets, cosmesis and augmentation markets, and reconstructive surgical devices, all of which are multi-billion-dollar markets on their own. To date, we have validated our regulatory strategy. We have completed all of our preclinical testing, save for the final verification of a few mechanical properties and the biocompatibility endpoint. And we have achieved one letter of intent from a distributor with a $50,000 contract for downstream product development. For the remainder of this year, we're going to use the funding that we have raised, $1.5 million, to undertake a 510(k) submission to the FDA, to initiate our first-in-woman pilot study internationally, and to finish up our quality system development, as well as to look for breakthrough status in our downstream devices. Next year, with a 510(k) clearance, we will have a product launch in our first sale and begin recruiting for a PMA scale clinical trial to expand the indications for use of the Bravo. The team consists of myself, previous experience in medical device commercialization, including the Impede that's sold by Shape Memory Medical. And I've worked with Elizabeth Lawson to develop the Bravo. She is an oncoplastic breast surgeon specializing in lumpectomy care with more than 30 years of experience. And she was one of the people who introduced lumpectomies in East Tennessee. She has access to a network of 50 hospitals in the region that would allow us for early adoption. Our financial officer is Todd Rossman, and he's had experience raising more than $100 million for medical device startups, including the Ohio-based Neuros. We are raising $3.5 million for our 120 patient PMA scale clinical trial and to expand our team of executives, as well as to undertake our initial product launch next year. With the remainder of this year, we will be undertaking our 510(k) submission and beginning our pilot study internationally. We have developed the Bravo platform, and we hope that you will consider being resilient with us. Thank you.
Great work, Andrew. Questions for Andrew, Resilient? Yes,
What's
uh,
Joe.
the clinical endpoint of the PMA trial?
Full resorption of the device. And that is dictated by FDA.
Any other questions? Yes, Dean.
We have had 50,000 in grant contracts so far. We're looking at NIH potentially for funding downstream devices. As you probably are aware, some of that is in flux currently, and we'll have to see how that impacts their view of medical devices moving forward. But we have had good success in looking towards what we might be able to submit. The reviewers have been very positive, and we have identified several mechanisms we can use specific to femtech that is increasing in popularity.
Time for one more question, if it's out there. Yes.
What feedback have you gotten around the reimbursement pathway, considering this is more of like a cosmetic change related to the breast?
The reimbursement pathway depends in part on what indications for use we're filing under. And since we are providing temporary mechanical support, we're able to slip under existing surgical mesh reimbursement. So there are codes specific to breast cancer care related to those surgical meshes. And that's how we're going to approach this first. With a PMA scale study, with that in hand, we would be able to have either our own code through TPT or to expand the claims and see what that does. But early days, it will be existing codes, and they are identified for such devices.
All right, one more round of applause for Andrew, Resilient. I'm going to turn it over now to Howie again to talk about InnovCares, our next company, and the founder, Mo.
Can everybody hear me? This doesn't sound like it's on, is it on? Hello, can everyone can hear me? Okay, great. I suspect a lot of people in this room have spent, just like I have, a lot of their career in healthcare. And perhaps you're somewhat as frustrated as I can be every once in a while when you see such unbelievable talent, such unbelievable technology. You know, we're in Cleveland now with incredible physicians and institutions up from Boston similarly. But then you hear all these terrible things about poor population outcomes on certain conditions. And it's devastating spending a career dedicated to a field and seeing so hard to move the needle. And what's amazing is, I'm sure you would agree, we're learning every day what some of the core factors are that make these things hard. But just because we're learning more and more about things like societal and social determinants of care that drive challenges to better outcomes, they're not easy to solve for. So the more we learn, the more we realize how difficult these things are. What is amazing about InnovCares and Mo is they've somehow figured out a way to package up an unbelievable combination of technology, partners, and services that can move the needle. And they validated they can move the needle. But what's even more impressive about this company is they then figured out how to find who's willing to pay to move the needle. And they've proven they can win business with these partners. I got to tell you, when you meet Mo, you're going to realize what I've realized. He is 24/7, unbelievably energetic, passionate, and gets shit done constantly. Don't know how he does it, but then you get to know him and you realize he's got a heart of gold. Unbelievable guy. And so I can't wait for you to hear what he's been doing and how far he's taken this company and where they're headed. Mo, come on. Thanks.
Thank you. Hi, everyone. My name is Mo. I'm the founder of a company called InnovCares, where we're improving care delivery for mom and their babies. Started the company, unfortunately, after my sister passed away in childbirth due to pregnancy hemorrhage in Sierra Leone, where I'm originally from. And then my aunt, a few years later, died of preeclampsia in Columbus, Ohio. So two different worlds collide, causing this death. And so immediately I said, how can we solve this issue? And so I created enough cares out of that burning desire to solve the issue for maternal health. We can click. Oh, there we go. It just takes time. And it moves fast. And so we've proven that the fact that 60,000 moms die annually is really heartbreaking. And how do we improve for that? Not only that moms are dying, but it's also very wasteful and costly. It costs us $32 billion. And that's unacceptable. A lot of these conditions are actually preventable. 80% of them are preventable. We've shown to improve that. We've dramatically improved C-section rates in Texas by collaborating with Blue Cross Blue Shield of Texas and deploying in federally qualified health centers. We've improved C-section rate by 37% and preterm birth rate by 38%. We've also managed to save the insurance payer, Blue Cross Blue Shield, almost $500,000. And I'll tell you a little more about the platform itself. It's two mobile apps that are software, a patient app and a provider app that connects back to the EHR. When a mom walks in, not only do they get access to the technology, they also get access to this kit. And this kit, there's a blood pressure device and ultrasound that they take with them at home. Really, it's a comprehensive AI technology itself. And I'll bring to your attention one of our patients, Chineye. Chineye came to us in the second trimester, really experiencing complication, second pregnancy, and we were able to connect Chineye during her visit with HHM Health, which is the clinic in Dallas that we partner up with. Chineye had got this kit. She was able to connect her blood pressure device because Chineye is diagnosed with hypertension and as well as gestational diabetes. She was able to we were able to closely monitor her, the MFM clinician monitor her closely with a nutritionist, and she's able to book rides to and from the clinic. Transportation to the clinic, medications, and then request for health negotiation to be sent to her home. All arriving safely. At the end of her pregnancy, she delivered a healthy baby boy. So it's three people that we're actually able to improve care for, right? The moms, healthy mom, healthy baby, which I think all of us really want in our society. But secondly, providers. Instead of the provider, the clinician spending time managing logistics, we're able to address that social determinants of health really simply by transportation, rather than them spending their time just for doing that. They're now focused on providing care. For the insurance payer, we'll boost engagement and satisfaction, and as well as they get real-time data. So what happened last year? We did $1.1 million in revenue between Blue Cross Blue Shield of Texas and Illinois. It took us 4 months to close Blue Cross Blue Shield of Texas. Usually, traditionally, it takes about 12 to 18 months to close a deal like that. We also closed, while we're executing this in Texas, we're able to close Blue Cross Blue Shield of Illinois in 2 months. So now we're deploying in Illinois as well. We're projected to make about $5 million this year in revenue and deploy in both Alabama, Florida, and Georgia. Let me tell you a little bit about the Alabama deal. The Alabama is with the University of Alabama Health System, which will bring us $3.5 million in revenue. Heavily software, as you can tell here, less on the remote monitoring side or people side. Again, high margin. So how do we make money? We charge a simple fee, a bundle fee that we contract with them with the payer. The payer pays us upfront, and then we go and serve the patients and collaborate with the hospitals and the clinics. We reach major payers, not just through the insurance company by partnering up with them. We also reach those payers by collaborating with the health systems and the federally qualified health centers. So they give us inbound referral to those insurance payers that we collaborate with as customers. So huge market, it's $1 trillion for women's health. $160 billion of that is maternal health. 1% of that is serviceable, adjustable for us at 1.6 billion. We've got ourselves protected as well, 2 patents, a design patent and a utility patent. Incredible team that's really solving for this issue here. I came more from a healthcare finance background. I was a CFO for a behavioral health clinic down in DC where we actually launched the platform. And also then Lovemore came from more of the insurance payer side. And then we've got a CMO, Dr. Eribo, who actually is the medical director at HHM Health currently. We're continuing to scale, projecting to make $29.3 million in revenue in the next 3 years. And what does exit look like? Because we partner up with insurance plans, we were potentially going to exit with one of these payers or roll up to a private equity. Again, we have an end-to-end platform that is a category defining asset that's more valuable than a risk certification tool like SolutionWorks that sold recently, right, for $150 million. We're raising $3.5 million in order to expand to those markets that I mentioned earlier, which is California and UOB Health System. Again, it's not just managing and supporting the moms, it's also leaning forward into value-based care contract to also build for those services that we're providing virtually prenatal and postpartum care using existing CPT codes. Again, my name is Mo, and I'm the founder of Enough Cares, where we're closing the gap in care delivery for moms and babies.
Thanks so much, man. Any questions for Mo? Go ahead.
So I noticed, I think the acronym was MMH. It looked like maybe kind of a nonprofit or something that you partner with. Is there a way? Oh, yeah, okay.
Yep.
HHM, sorry.
Mm-hmm.
There's an organization in town, Birthing Beautiful Communities, I think is what it's called. Are you familiar with that?
I am, but I haven't talked to them yet, but happy to chat with them.
Okay.
So these guys here, they are federally qualified health centers.
Oh,
so they have their own clinics, and it's usually in several sites. They have about 7 or 8 sites.
Okay. I was just thinking that this group might be a way to kind of help you connect with communities.
Absolutely. Please connect us.
Okay.
Yeah. Yes.
Remember, connections and capital, like Kaylee said, right?
Yes, please. Please.
All right, anyone else? So one more question for Mo or Enough Cares. All right, well, you crushed it. So thank you so much. One more round of applause. All right, next up is TigoSense, and here's Ethan.
Hi, my name is Ethan Cohn. I'm an EIR here at JumpStart. Heart failure is one of the leading causes of death in the U.S. and the world. In the U.S. alone, approximately 7 million Americans suffer from the disease, and unfortunately, 4,000 patients will die every year from heart failure. A major inhibitor to the treatment of treating heart failure is the fact that we lack a non-invasive, affordable device to accurately measure the progress of the disease. Because we lack this device today, 20% of patients are readmitted to the hospital within 30 days after being discharged, and the cost of the healthcare system for every patient that's readmitted is about $20,000. So what do we do about this problem? Well, enter Abe Joseph, the CEO and founder of TigoSense. TigoSense is poised to transform the treatment of heart care failure, as it has developed a patented, specific, and affordable solution that enables the accurate monitoring of the advancement of heart failure at both the home and in the hospital. His solution promises to reduce the readmission rate by up to 50% for heart failure patients. So please join me in welcoming Abe Joseph.
Thank you, Ethan. Heart failure is a global problem. Over 60 million people are impacted globally, and half of them will die within 5 years of their diagnosis of heart failure. It's a significant issue, which I'm familiar with from my time at American College of Cardiology. And personally, I understand the emotional toll it takes on a family because I've experienced it from the death of a family member. So it's a significant issue with no good solutions in place. So in the US, heart failure is the single largest readmission rate in the country. Every readmission reduces the lifespan of a patient. And it's an economic issue as well. $16,000 to $26,000 for every patient readmitted, besides the penalties and all the other economic issues at the hospital you face. Now, since it's a big issue, there are current methods out there, but they're invasive, costly, and non-specific to lung fluid congestion. And congestion is the reason why they end up in the hospital. And hemodynamic congestion is the issue where they end up in the hospital. Specifically, lung fluid from hemodynamic congestion, which is fluid leaching into the lungs when the pressure and volume increases. So our device is a reusable device, as you can see here. And the patch is consumable. So we have two revenue streams there. The device itself was designed for accuracy with patent-protected technology, patents issued globally in the US, Europe, and other countries as well, and others are pending. And it's a radio frequency technology underlying it. So our pilot study, where we tracked net fluid load of a patient over an 8 days, this is one of the patients which stayed 8 days. You can see length of stay is long. The blue line represents the net fluid load. You can see that the fluid is decreasing. At the same time, we tracked it. The dotted green line talks about looks at the lung fluid, and we tracked it very well. Now, for FDA approval, we need a 510(k) approval. We need to compare it to a gold standard. In our case, we are comparing it to CT measurements of lung fluid. And as you can see from this preclinical study, 95% correlation of our reading to what the CT measured. Excellent, excellent results there. And the variation is very, very acceptable from the Bland-Altman test for patient management. So, as I mentioned, there is competition out there. We put it into 3 buckets: invasive and surrogate measures, and then fluid measurement. Invasive are just what they are, and because of that, they're expensive, and they're limited to very sick patients. The surrogate measures do not measure lung fluid. They try to tell you the heart failure is worsening. They do not tell you what's going on with the patient with lung fluid. There is fluid measurement devices out there, but they are significantly expensive and also limited by FDA for what patient they can be used on. So here's where we come in and our value proposition. If you look at this triangle, you want to avoid getting to the apex of the triangle, which is where an hospitalization event happens. You want to be at the extreme left of the triangle, which is where we are going to be. That is where the invasive solutions are, about 3 weeks early when you detect hemodynamic congestion. On the apex of the triangle, you're detecting clinical congestion. That's where you're looking at symptomatic things, and that's too late. And that's why these patients are suffering. So we did a customer discovery with clinicians. These are cardiologists, heart failure cardiologists, emergency medicine doctors. They love what they're seeing, and they have agreed that they have a significant clinical need for a product like ours with a significant value, and if available, they will use it very often. So from a market entry steps, we are moving along quite well. We are right now getting ready for a pivotal study, and that's what we are raising funds for. It's a 55-patient study, already talked to FDA about it, and they are on board with our plan. The next is after that is getting to the initial target sales. We'll go after large academics because that's where the KOLs reside, and then additional clinical studies to support it. So it's a large market, like I already said, and we are going after the 10% of the worst and the sickest patients. When I say worst, I mean sickest patients. And that's about 10% of the total market. Our business model provides for multiple revenue streams, from device sales, for recurring sales, from patient monitoring, and also from patch sales. And also provides accretive benefits to hospitals and providers because they can reduce readmissions, they can reduce length of stays, and free up beds. What are we looking for? We have raised already $2.2 million to get up to where we are now, and we're looking to raise $3.2 million in the next round. That will take us through FDA clearance in about 2 years. And then after that, 6.8 to get us to commercialization and self-sustaining. That's the layout of the cash use. And our team is a proven team with deep experience. Dr. William Abraham, who's a co-founder along with me, he is the preeminent heart failure cardiologist in the world. And he has been associated with CardioMEMS and other exits in the market space. Dr. Emery Urton, he's the engineer behind it and the professor at OSU, deep DARPA experience, and that's where the technology comes from. It's a radar technology. Dr. Ernst Stooge is a chairman of a board, ex-Abbott, ex-Medtronic, 10 exits, two unicorns. And Flavio and David are our business side of support. So what are we looking for? Looking for your support to get us to where we want to go. We have a solid market, we have a solid team, and an excellent solution to make a difference in this space. And we believe we can have an extraordinary return in the next 3 to 5 years because we have talked to strategics and they're very interested in what we have. Thank you for your time. And if I can answer any questions, please do.
All right, you know the drill. Questions for Abe and Tigo-sans? Oh, this way. Sorry, go ahead.
And so what's the business model or the cash flow? Like, so who's your customer? Who's writing the check? Is it hospitals stocking it? Is it cardiologists prescribing it? How does that work?
All of that.
Okay.
Yes, exactly right. Hospitals who are buying it, and then the cardiologists who are prescribing it. And if the hospitals have a monitoring service, they can use their own, and we charge the fee for the device and our own data fee because it's unique to us. Or we can provide the monitoring service ourselves.
Anyone else? Yes.
I can do that. Okay. Just to follow up on that question, would this be considered like a sub-capital expense, or is this going to, like, where in the process?
Yes, exactly. When we price the product and we're looking to price the product, it is not a capital expense.
All right, one more round of applause for Abe and Tigo-sans. All right, Ethan, gray mat.
Thank you.
The Obstacle is the Way is a critically acclaimed book that provides powerful examples of how leaders have transformed obstacles into opportunities. Michael Gray, the CEO of Gray Matter, is another one of those leaders. U.S. hospitals are facing a staffing shortage. While demand for nurses continue to rise, nurses are quitting in record numbers, and the agency fees alone for finding replacements for those nurses is estimated to be $13 billion a year. Seeing an opportunity within this obstacle, Michael recognized that the core issue is not simply a shortage of nurses. Rather, it's burnout that is driving turnover. Digging deeper, he discovered that the root cause of the issue is that the nurse-to-patient assignment process remains largely manual and relies on limited data and lacks a formal feedback loop. Collaborating with an outstanding team of economists, physicians, data scientists, nurses, Michael has developed a solution that will fundamentally transform this process, reducing burnout and improving the patient experience at the same time. Hospitals and network and their nursing teams are so enthusiastic about his approach that they are now actively pursuing his team to work with him on developing this product. So please join me in welcoming Michael.
Hi, I'm Mike Schwartz, and I'm the founder of Gray Matter. And I want to thank JumpStart and Ethan and Jackie and all the fellow members of the cohort. It's just been an honor to work with everybody and a fantastic experience. I have spent 30 years as a strategy consultant and entrepreneur in healthcare. Alongside the heroism and boundless compassion of the doctors and nurses who care for us all, it is appalling and horrifying to see how the industry actually operates on the inside. Imagine you are 6 months out of nursing school. You are a med-surg nurse covering 7 patients, even though the standard ratio is 4 because the unit is short-staffed. The med-surg unit is the largest part of the hospital. The hospital's bread and butter, where patients come from emergency, general surgery, and direct admits, many for recurring episodes of chronic disease. Not all nurses are the same, and not all patients are the same. Among your 7 patients, 1 is on an insulin drip, which you are not qualified, or you are not certified to manage. Another is bipolar and homeless, and you have no experience in behavioral health. A third speaks Vietnamese, which you don't speak. And a 4th patient has multiple wounds from a car accident. But it is on your unit, but the patient is on your unit because the ICU, where the patient should be, is full. You are ready to quit nursing. Let me say this again. Oh, I'm sorry. Okay, so let me say bad assignments cause bad shifts, and bad shifts cause nurses to quit. The turnover rate in med-surg is 3 times the rate in the rest of the hospital. That means that over 80% of all nursing turnover is in the hospital in the med-surg unit. In fact, the nursing shortage that we hear so much about is really a problem of turnover in med-surg, and that in turn can be traced back to bad assignments in med-surg nursing. So how big is this problem? Across the healthcare workforce, it is conservatively worth $13 billion a year, which is the direct cost that hospitals incur to pay staffing agencies to replace workers who quit. This does not include agency nurse price premiums, overtime, longer length of stay, costs of lower patient satisfaction, and loss of human capital. With 4,500 hospitals, the direct cost alone comes out to about $3 million per hospital per year. On average, 160 care workers per hospital, including many nurses, leave their jobs. It costs $18,000 in direct agency fees alone to replace each worker. The solution we have built to help the charge nurse make better nurse-to-patient assignments is our software and benchmarking product, NurseMatch. First, NurseMatch matches nurses to patients. Not all patients are the same, and not all nurses are the same. Patients vary according to medical acuity, psychological needs, and social determinants, including language. Nurses vary according to certifications, experience, language, and preferences. The product delivers recommended matches between the nurses and patients to the charge nurse, who then makes assignments. Second, NurseMatch recommends adjustments and support staffing so that collectively The workload is manageable and distributed evenly and fairly based on predictions using gray matter proprietary productivity benchmarks. Third, NurseMatch collects feedback from the patients and nurses at the end of each shift, and then compares actual to predicted workload, again, against proprietary benchmarks. The algorithms update, so the system gets better and better, and the charge nurse also gets better and better at making assignment decisions. The reason NurseMatch can do what I just described is that we use multiple different types of data, shown on the left, that collectively and dynamically represent the healthcare system. We've assembled a cross-disciplinary team of experts, shown on the right, who specialize in building models using just these kinds of data. The combination allows us to develop algorithms that match nurses to patients and then nurses to the rest of the care workforce and to technology, enabling us to dynamically match patient demand for care with the capacity to deliver care on a continuously evolving basis. We have a product roadmap. In the first 6 months, we're developing and implementing the minimum viable product and assembling the algorithms and reference data set to establish the productivity benchmarking product. To prove out the MVP and build the benchmarking reference data set, we are assembling our own core ecosystem of 4 to 5 health system customers and data providers. We're working with 3 existing ecosystems, Abundant, Hatco, and Dandelion, to assemble the ecosystem. We're raising $1 million now to assemble our core ecosystem, implement NurseMatch, and build the reference data set to our productivity benchmarking. And over the next 18 months, we're building the solution to the chronic workforce shortage in healthcare, and would love to talk to you about joining us along the path. Thank you.
All right, any questions for Michael and gray matter? Yes.
Great presentation, thank you. I'm familiar with like software programs that like take a TAVR program, which is the similar everywhere, like a heart valve program, and then fit it into the hospital network where the mapping's easy. Tell me more about the mapping here, right? You show up at a hospital. How do you get ground truth for the people and the expertise there so the network, layers itself and you can extend the model? Thanks.
Yeah. So we are intentionally swimming against the tide in that respect because we're integrating data which are in silos in the hospital, right? If that's what you're getting at.
Well, you tell me, right? You have people that have expertise. You want to make sure they're showing up at the right time in the right place when they're not exhausted.
Okay.
So how do you encode
So this is getting in.
Truth of that human resources expertise.
Right. So this is getting into. So I'd actually like to talk to you about this later on the side if you don't mind. But basically, what we're doing in the system is matching tasks to skills. Okay. So the patient represents the tasks, and we break that down, and that's where a lot of the AI comes in. And the nurse represents a set of skills, and they're different skills for different nurses, and we have to match those. That's what it does.
So you just need their certifications, for example, and
initially it's certifications, experience, education, all sorts of criteria that we collect on the nurses, which, by the way, if it resides anywhere right now, it's either in the nurse manager's head or it's in a binder, and every unit is different. And part of what we're doing is addressing that problem and standardizing. Okay.
So is there any risk of harvesting the EMR data from the patient? I mean, you're harvesting patient side information out of EMR. That's got HIPAA compliant problems. Marrying that with the nursing.
So we are not taking possession of any client data. We're bringing the compute to the data. So whatever security there is the client security. What we are taking possession of is the benchmarks based on the data. So we'll run the computations from a combination of the EHR and the ERP system and the billing system and all those other things and create benchmarks. Those will be ours, but the PHI stays in the client. All right, I think that's it.
Yeah, if
you
there are any
very-
more questions, we can find Michael afterwards, but thank you so much. One more round of applause for saying that.
Thank you.
All right, and we have one last company, John from Vitranew and Gary.
So pleasure to be up here again, and pleasure to introduce John Black, CEO of Vitranew. John and I have known each other for a little over 10 years, I think. I met John when he was co-founder and CEO of MediView XR. MediView XR is a spin-out Cleveland Clinic technology that John had taken through a number of key milestones. The company continues to grow, and John has had an opportunity to exit and take on some new projects. So as leader of Vitranew, a seasoned MedTech executive, he's working on a really interesting novel drug delivery platform, I'll say it, and he's going to go into much more detail, that is just something that is so unique and proprietary. I'm anxious to see what your reaction is. So this delivery platform is targeting a beachhead market that will revolutionize the treatment of ophthalmic diseases such as wet macular degeneration and other kind of related diseases. Vitranew in this technology will dramatically improve patient compliance, which is a big issue now because currently the disease is treated with ophthalmic injections on a monthly basis. And in doing so, he'll dramatically improve outcomes for those patients. So, John?
Thank you, Gary. Aside from creation itself, I would argue the most precious gift we get in life is vision. Right now, we're being robbed of our vision. A disease state known as age-related macular degeneration is the leading cause of blindness across the United States. Many of you in this room know a loved one or somebody close to you that is being affected by this disease today. We have excellent treatments that have emerged to treat this condition. The problem is it's a life sentence. You have to have an injection as frequently as every 28 days for the rest of your life. This has hit my family too. My grandmother has been diagnosed with age-related macular degeneration, and at 94, she is choosing to go blind versus drive an hour into the city to get her treatments. So this is a very, very real scenario. It hits home for me. I know it hits a lot of people in the audience as well. This adherence is awful, shameful within our medical community that we drop 30% over the first year. The problem is so eminent that retinal surgeons across the US for 3 years running have said this is the #1 problem facing our profession is the durability of these treatments. The reason that this problem has come to pass is the evolution of therapeutics. Up until this decade, therapeutics were designed to be heat stable, pill form, you could take them and you'd be treated by that therapeutic. With monoclonal antibodies and genetic medicine, these compounds and therapeutics are incredibly powerful and effective, but they are very sensitive to changes in pH, changes in temperature, or addition of any kind of a molecule to help with delivery. Vitranew's solution, an injectable, dissolvable microcapsule. Made with the same polymer from the gel capsules that you take when you have a fever or something like ibuprofen, this microcapsule incorporates a technology of microporosity, nanoporosity, that allows the therapeutic agent to seep out of the microcapsule and dissolve over time. This microcapsule is unique because it is the only technology that can hold the purest, unadulterated form of the therapeutic agent. No processing needed, no attached molecules. This microcapsule will take that pure form of the therapeutic and deliver it to the eye.
What you'll see on the screen is the current dosage that we use today. And what you'll see up here is we have this peak. So our strategy is to put as much of this therapeutic in as we can, just below toxicity, and then watch it drop off very rapidly. The curve that you see in color there is what the microcapsule can actually achieve, that we get a steady state release of the therapeutic above therapeutic threshold for a longer duration of time, actually reducing the overall dosage requirements. We can handle a lot of emerging therapeutics. Right now, we've got a great clinical evidence portfolio around monoclonal antibodies, and we have early evidence within small interfering RNA. But this microcapsule is unique in that after it delivers its therapeutic, it will dissolve and be absorbed harmlessly in the body. One of the things that drew me to Vitrinu was that this was one of the few technologies I've ever seen that has this much clinical data this early. They have a cover article, peer-reviewed preclinical evidence showing no inflammatory response and the ability to deliver the leading therapeutic used for wet macular degeneration, typically a 28-day dose, up to 9 months. So this is very impactful. We also took a little bit of a risk. Another company called Genentech has a therapy called Vabysmo. We may have acquired this through Ohio State University, sent it to Canada, had it tested, and we'll be releasing the 6-month data showing not only are we still eluting the therapeutic, but the therapeutic is active, which means it will bind and do exactly what it's supposed to do. So this represents a small portion of the research that needs to be done, but we're also moving into genetic medicine. Small interfering ribonucleic acid is a study that we're getting the results from right now, and I hope to have these results soon so that we can start to share these other emerging technologies and therapies on how we can give a sustained delivery solution. And as you may have already figured out, our customer is the pharmaceutical company. We develop a microcapsule, but we do not develop the therapeutic that goes inside of it. And so we use a licensing model. We're this close to landing a big agreement. We're just a little bit too early. But this licensing model is very lucrative for companies like us, developing a small reoccurring charge that comes back. And this licensing model allows us to participate in milestone-based payments as regulatory achievements are accomplished, and then also ongoing low to single-digit royalties. And it is a partner-rich landscape. Right now, there are not many therapeutics that are actually on market for these retinal conditions. There are over 400 indications being sought for preclinical phase 1, 2, and 3 therapeutics right now, representing a real opportunity and the clearest thing I've ever seen within a startup of product market fit. We talked about this being targeted towards age-related macular degeneration. So our aging population, my parents, my grandparents, they're really driving the need for this. The therapeutics have moved so rapidly that this is one of the fastest growing fields, as our vision is one of the most precious things we're ever going to receive. There is a huge investment to treat these conditions. And so our market is large and it's growing. And what I'm going to show you in a little while is it's not just based in the eye. Right here is kind of what I'll call the mic drop. If I could show this medical advisory board, leave this slide up and walk away, for those of you who have worked within ophthalmology, you would know that these are not just key opinion leaders. These are the opinion leaders. They're conducting the pharmaceutical studies on these agents. They're advising the major pharmaceutical companies, and they've agreed to join a small startup out of Ohio to help deliver this technology to the market. Our founders, Caitlin Swindle-Riley and Dr. Matt Orr of The Ohio State University, are also phenomenal. They are so dedicated to patients, it's humbling for me. And so I look at this slide as me being the most irrelevant on here. As Gary said, I had the opportunity to be the founder and CEO of MediView, which recently achieved a 9-figure valuation. And prior to that, I had 4 startup exits, primarily within sales, one of them being OrthoHelix, which a lot of people in this room have invested in. So I got to be their #1 sales rep early in my career. I like to say sometimes we fall up. This is an injectable, dissolvable microcapsule, not just for the eye. So we're encouraged by early conversations we're having with hospital systems in the area on how we can move this throughout the human body. I think this has great applications and things like renal tumors, things that you can deliver a more durable therapy to an affected body part. And if we could even put a thumb on the scale of shifting our treatment philosophy from systemic IV infusions of these therapeutics to local episodic treatment, I think we can have a real impact as an Ohio technology and as a successful exit. I'm also very, very humbled to announce that thank you to the JumpStart team. 4th of July, we were having more than just celebration of our independence. We closed our bridge round. So I've got some of our existing investors here. So we now have operational capital to get through some critical milestones and start to recruit strategic investment and lead towards our Series A. We're going to be focusing our time now on business development and quality management systems. We can build this microcapsule into a 22 gauge needle for injection. Bigger is easier, but we need to get good quality systems down so we can engage the different pharmaceutical companies very, very aggressively to find therapeutics that are in need of a delivery system. So this is where we're at right now. On behalf of everybody within the cohort, I think we can all say we're very, very humbled and grateful for JumpStart to be part of this new program and for a full packed room today. So thank you and appreciate your time.
All right, one last time. Any questions for John? Yes, a couple at the back of the room.
I'm curious about your manufacturing scale up of anything particle based. Is it particle? Is it a micelle? Like what type of actual capsule are you talking about?
It's a polymer. It's a blend of polymers that Ohio State, Dr. Swindle Riley has actually optimized based on the charge. We've been very, very fortunate to find a potential contract manufacturer that is actually the polymer supplier. So a company called.
I was going to say because most wouldn't touch this type of scale up with a 10-foot pole because you get very specific. One set of equipment is one product and it gets used. Correct. One day a year.
Gary could testify. I lost a lot of nights of sleep worrying about how do you scale up manufacturing of something so small. Everything from the chain of custody to the polymer through the electrospinning process to make the microcapsule to aseptic filling and sealing, our manufacturing partner and supplier Evonik can handle. And right now we're in very, very deep conversations to move our quality management system and our design to a scalable manufacturing process. And that's why the focus with our partners over at JLEX, who I've worked with before, is making sure that quality management system and the process is transferable. Great question. Kept me awake a lot.
Great presentation. When you're looking for pharmaceutical partners, are you only looking at therapies that are looking for a delivery system, or are you also looking for pharmaceutical manufacturers who are looking to repurpose their drugs into a new delivery system?
Both. So there's a speed advantage with using on-market pharmaceuticals because they already have existing safety data, and we're typically going to reduce the overall dosage. But the number of drugs seeking indication, we're fearful of only focusing on market because we know that these emerging therapies are changing so radically. So part of our participation in JumpStart, we've proposed and identified with our analysts and our mentors actually doing a business development study and a pricing study to make sure that we're in the right spot. So our intention is to participate in the next phase of this cohort, which is partnering with some of the preferred providers to do that. That's a great question.
Yes, one more.
This is great. You did indicate that mainly focusing on the visual application and other tumor related. Do you think that will work for orthopedic application as well?
So I spent 10 years in pediatric deformity correction. So I think that you could use this for potential tendon. So we recently filed some IP on osteosuppressive delivery. So think of a limb lengthening treatment. So you have to break the child's bone and you have to derotate it and then you have to extend it slowly. The problem that you face is the bone heals faster than the soft tissue can stretch. Huge problem. So you're constantly breaking bone, stretching nerves. If we could put some kind of local osteosuppressive at the site of the osteotomy, that's an orthopedic home run. That's getting into the weeds, but we did file some provisional IP on it. And then I reached out to Steve McCormick at Orthopediatrics to see who the best KOLs would be. I haven't worked in the industry for a while, so the guys that I came in with, they're all retired.
Wonderful. We should talk then. Great, thank you.
Thank you.
Yes, one more round of applause. Thanks so much, John. I've got a couple quick points. I don't want to keep anyone too long from their beverages and their networking, but a big reminder for everybody that's here today is that upcoming for JumpStart is a massive event that we host every year called Ohio VC Fest. It's going to be happening on September 16th and 17th this year. And if you don't know, or if you're from out of town or you've been under a rock in Ohio for a while, there's speakers, there's panels, there's investor one-on-one meetings, which are a huge part of the event. There's a product demo zone that we encourage you to look at and apply for, or encourage some of your friends and startup companies to look into. And there's absolutely tons and tons of networking that happens at this event. The other really cool part of this event is that the corresponding cohort of companies, the one that will come right after this healthcare cohort that you just got to see today, will be presenting at the event. So their showcase day is Ohio VC Fest, which is so cool to me. And so we encourage all of you to come be a part of the event, but you'll get to see another cohort of companies come through and present in front of a much larger audience and on a much bigger stage. So that'll be a wonderful, wonderful event. One additional point is that our next cohort of healthcare companies still has applications open. So if you are close to a startup founder in the healthcare space that's looking to be a part of a program like this, or that you could see being up here and being successful in the ways that all of these startups today have demonstrated, please share that applications are closing at the end of this month on July 27th. If you have somebody in your network like this, please introduce them to me or to one of my team members, Kaylee or Evan or anyone from the JumpStart team. We'll route them where they need to go. But really the important part is forging that relationship with that founder. So thank you in opening up your networks in that way. And a final thank you just goes out to a couple people. One is to the rest of my JumpStart team who have worked tirelessly to get these companies the support and the level of dedication that they have to local companies and local support for startups in this space is incredibly admirable. And I'm proud to work here every single day because of that. Our EIRs are inspirations. They're incredibly experienced, and I think that the program would not be what it is without these specific 3 EIRs that you heard from today. And I love hearing how they talk about their companies and the stories behind the founders. So deeply appreciate them. All of our guest experts that come in and dedicate their time and their talent, all of their treasures to supporting the startup companies, and they donate their time for that. We really appreciate that. And a lot of them are from another group that I want to call out, which is our preferred partner network, whose resources and guidance and support and services all get the companies hitting milestones that get them ready for these fundraisers. And the last thank you is for all of you here today for doing, as Kaylee mentioned earlier, what we hope to smother the companies in, which is connections and capital. So one more round of applause for everyone that I just mentioned. Thank you so much.